Thank you very much, Tom. So these are my conflicts. So I'll be talking about rheumatic mitral valve stenosis, and balloon valvuloplasty is aimed at treating rheumatic mitral valve stenosis as opposed to degenerative mitral valve stenosis. So we'll talk about indications, contraindications, pre-procedural assessments, and some procedural steps and complications to look out for. So it's more common in women than in men, this condition. It's more common in patients who are from developing countries. And in the UK, we have a large community of people from Asia. And we seem to be treating a lot of these patients who have mitral valve stenosis with this technique. Other reasons why the mitral valve can become stenosed are degenerative changes with age, and the pattern of calcification and changes to the mitral valve are quite different compared to rheumatic. Chest radiation is another reason why mitral valve stenosis can also develop, as well as carcinoid disease of the heart when there is some form of communication with the systemic circulation. So rheumatic mitral valve stenosis is usually characterized by fusion of both commissures. And you can see here that the commissure on the left is a typical fibrotic fusion, and on the right, the fusion complicated by some calcification. So the presence of calcification makes it more complicated to treat with percutaneous techniques. This is important because the whole goal of this technique of balloon valvuloplasty is to actually open up the commissures which are fused. And if they're fibrotically fused, they're more likely to respond to balloon valvuloplasty. If there is an excessive amount of calcification around that area, then it's quite unpredictable what happens when you inflate the balloon. Now, this is some data from Japan, showing patients who have had valvuloplasty. And in patients who have complications from their valvuloplasty, for example, a tear in the anterior leaflet or the posterior leaflet, this is known as excessive commissurotomy. These patients have poor survival, and these patients usually end up with some form of mitral valve regurgitation. And then the patients who have usually a unilateral response to balloon valvuloplasty seem to have better survival compared to the patients who have bilateral commissurotomy in this cohort of patients. The recommendations from guidelines are that we should be using a scoring system to try and understand whether the patient is going to have a good response to this technique or not. And you may already be familiar with the Wilkins score, but other scoring systems include the Cormier score and the ECHO score revisited. And these are recommended to be used in some format. So the Wilkins score is something that we tend to use more regularly in our institution. And the Wilkins score focuses on mobility of the leaflets, the thickening of the leaflets, the degree of calcification of the leaflets, and also involvement and thickening of the salvalvular apparatus. And these are graded from 1 to 4. And so, for example, when there is a very minimal movement of the leaflets, this patient will score a 4. When there's excessive calcification, then they'll score high. So the maximum score you can get is 16, and the lowest is 4. And the ideal score for considering a patient for balloon valvuloplasty is a score of 8 or below. However, in cohort studies, even scores of 9 or 10 may also result in good outcomes. This is the Cormier score, which looks at mobility of the anterior mitral valve leaflet, and also assesses, based on fluoroscopy, the degree of calcification and movement of the mitral valve leaflets. The ECHO revisited score takes into consideration the valve area. So if the valve area is below 1, the patient's score is already 2, And other factors that they look at are subvalvular involvement, commissural area ratio, and also the degree of leaflet displacement. The higher the score, the worse the outcome is from percutaneous mitral commissurotomy. The guidelines recommend using mitral valvuloplasty in patients who are symptomatic and who have favorable anatomy based on the scoring system, and also patients who are symptomatic but high risk for surgery. And they also give a class 1 recommendation for patients who are symptomatic but unsuitable for PMC. Those patients should be ideally considered for surgery. However, the patients who are still symptomatic but high risk for surgery and have unfavorable anatomy, other things to take into consideration are clinical and anatomical considerations. So even Wilkins scores above 8 could be considered in some of these patients. Patients who are old, who have pulmonary hypertension, who are really unsuitable for surgery are the ones that we sometimes end up considering them for valvuloplasty. This is a schema in the current guidelines from the ESC, which are going to be updated in the next few months, about where PMC or valvuloplasty is located. And essentially it summarizes what I've just said in the last 2 to 3 slides. So contraindications are the following. If the valve area obviously is above 1.5 centimeters squared, this valve area is too large could be considered for PMC. Presence of left atrial thrombus is an important feature that we always look for. So this is an example of a patient we were going to do a valvuloplasty on, and we found that they had thrombus, so we ended up not performing this procedure. Other considerations are presence of severe or bicommissural calcification. So you can see on the 3D image at the top left that this patient has a lot of calcification around the annulus. The commissurals are involved, and a very small mitral valve orifice. The 2D pictures at the bottom demonstrate the degree of calcification as well. And this patient we would consider if this is the only option for them, but it's quite unpredictable what happens when you inflate the balloon in this group of patients. So I'd like to present a case. This is a 78-year-old lady who's got mitral valve stenosis. You can see the hockey stick anterior leaflet motion. This high velocity during diastole in this patient who's got severe mitral valve stenosis. So this is what their TOE looks like. So we scored their Wilkins score as being 10. We took the patient to our heart team discussion, and we decided that this patient should be considered for percutaneous mitral commissurotomy. We found that the patient had some sludge in the left atrial appendage, and sometimes when it's like this, or you're querying whether there's thrombus, we tend to use SoniView contrast. And when you use SoniView contrast and give some time, you have enough heartbeats, you can see that the contrast fills in the left atrial appendage. That gives you reassurance that you can proceed on with the procedure. So this patient's mitral valve area was assessed using multiplanar 3D imaging. And this is the technique at the bottom left of the slide, where you can position the tips, the planes at the tips of the mitral valve in the opening position, and then use the bottom left to measure the actual area in 3D. And we also use the mean gradients as another way of judging the severity of the mitral valve stenosis. However, under general anesthesia, the mean gradients can be different to when the patient's awake. So the transeptal puncture you've seen explained beautifully before by Michelle is a similar process for using a bicable view and with X-plane. So on the left we have an inferior superior positioning of the septum, and in the right part of the image it's looking at the anterior posterior aspects. So once the transeptal puncture is completed, catheters are then passed through, and then the uni balloon is then passed and put into position. And this sometimes can be tricky, particularly in patients who have very small mitral valve areas, less than 1, to get the balloon across the valve. So sometimes it may take 5-10 minutes for the balloon to cross. Eventually, it does cross, and when it does cross, you can then have the opportunity of the operator has the opportunity of inflating the balloon and creating the homozerotomy. So here you can see at some point the balloon will inflate and then open up the mitral valve. So in this case, what we found is that the valve area changed from 1.09 centimeters squared to 1.44 centimeters squared. It doesn't sound like a lot, but the mean gradient also came down. And with this, we were reassured that this patient has a good result. And we also then look for complications after the balloon valvuloplasty. So what we look for are ruptured cords, a tear in the leaflet, and this is usually results in significant and severe mitral valve regurgitation. Sometimes pericardial effusion can develop from the transeptal puncture or from a tear within the mitral valve annulus. Other complications include systemic embolization and stroke, and also arrhythmias and heart block. So this is an example of a patient where we did a balloon valvuloplasty, but you can just see that there's a tear and significant mitral valve regurgitation. You can just see the tear here in the leaflet. So this patient ended up subsequently going on to have surgery at high risk. So in summary, the ESC guidelines currently recommend a scoring system to assess for suitability for PMC. As a part of the assessment, you need to exclude left atrial appendage clot. Sometimes you need to use Soniview or other contrast agents to try and reassure that there is no sludge. We assess the baseline severity of the mitral valve stenosis at the beginning of the procedure using 3D mitral valve area and mean gradients. And the guidance for the PMC involves transeptal puncture, guiding the NU balloon through the mitral valve orifice, then inflating it, and then measuring the valve gradients and the areas with each inflation. Sometimes several inflations may be required, and sometimes the balloons are increased in size to achieve better results. And as part of the assessment, once the procedure is completed, we look for complications such as mitral valve regurgitation from tears and also pericardial effusion. Thank you.
Right. So the results usually are not so smashing for our expectations, I would say. So when do you stop, and when are you happy? I mean, this was an elderly lady. She probably will not participate in the marathon. So probably that's good enough. 1.4, 1.5. When are you happy?
Yeah, so very good question, Tom. So I think you'll have a lecture from Rob Smith, who's in the background, who'll be giving a structural interventionist viewpoint on mitral valvuloplasty in a moment. But we tend to stop once we find that there's been at least a good increase in the valve area. And what we mean by good, I think a 0.3 or 0.4 centimeters squared increment, I think we find that it translates in some improvement in the patient's symptoms. Traditionally, these sort of procedures were done without TOE imaging guidance.
Yeah.
And we have a colleague who's based at a different hospital who has a large experience using fluoroscopy alone for crossing the septum and performing the balloon valvuloplasty, and not relying on mean gradients. I think until the patient goes to the echo lab or has a transthoracic echo at the end of the procedure. So I think from his experience, anecdotally, these increments, despite being quite small, still translate in some benefit in terms of symptoms. And it may buy patients more time before they end up having surgery, particularly if they're young, particularly when we start thinking about lifetime management of these patients who may be in their 40s or 50s, who have fibrotic mitral valve stenosis, rheumatic mitral valve stenosis, who may benefit from this procedure. But ultimately, I think majority of patients that I've seen only have a small increment, so we tend to reserve it for the elderly patients or the high-risk patients.
Yeah.
And
But most commonly, they're much younger than your lady, aren't they?
Yes, absolutely.
But I think a great talk. We do it not enough, I think, this kind of procedure, because actually it's the first therapy for rheumatic heart disease. So we don't diagnose this patient and don't do the procedure. Just for a few questions, how much time do you do it? So if a patient has a valvuloplasty, you have maybe an improvement and fusion again, so you redo it? First question. And second question, are you performing valvuloplasty in patients who had already a commissurotomy, an open one surgically? Is that a patient you would attempt as well?
Yeah. So again, Rob's in the background. A lot of questions. I'm sure he'll get an answer.
He doesn't know the answer.
Yeah.
So you have to, Ali.
Yeah. We can give you a microphone, Rob.
Oh, we can send.
Yeah.
Oh yes.
Yeah. So in terms of how often do we do this? So we tend to concentrate our mitral valve stenosis program. So currently there's 1 or 2 operators only doing it.
Mm-hmm.
And we tend to get referrals from our catchment area in Northwest London. So we're concentrating, and I think the numbers are currently in our institution are approximately just under 10 or just over 10 per year.
Yeah.
So it's still quite rare compared to the other procedures that we do. But it's better to concentrate it with 1 or 2 operators doing them, and or doing them together. In terms of the patients who've had previous commissurotomy, I think it's more challenging to perform this procedure on these patients, and often it's a relative contraindication to actually do it. But we often find that if the patients are high-risk surgery and there's not much option for the patient, we may consider it. I mean, we have done these sort of things. But Rob, please.
I think
how much time?
I think what's interesting is that there are more rheumatic patients out there now than there were when I was training. Not just in the immigrant population. We're seeing people of middle and lower class around London, the home counties, getting endocarditis, getting rheumatic fever. And I think what's interesting is that the default is still surgery. Certainly with us, because of the lack of experience of doing this procedure, these patients get referred to the surgeons. But when you see the guidelines that Ali showed you, surgery is mentioned once there. Actually the default should be valvuloplasty. So I think in answer to Fabienne's point, there are patients out there, but I think a good number are going to surgery, having mitral valve replacement at a young age, when perhaps those patients should be considered for a valve replacement delaying therapy. And as it's been proven, it's very good at delaying that need for the mitral valve replacement if it's done properly.
That's exactly the point. I think most of these patients go straight to surgery, and that's probably not actually, according to the guideline, that's not the first or the standard of care. Any remark maybe on this? It's very interesting topic.
I have a remark.
Yes.
So my lesson about pressure drop wasn't learned. But also, it is important because when you're putting a continuous wave across the mitral valve, the continuous wave doesn't know if you're looking at the mitral valve velocity gradient or the pressure difference between the left atrium and the left ventricle. So that is important because post-procedurally, particularly with edge-to-edge intervention, you can get high numbers of a pressure drop across the valve, but doesn't necessarily mean you've got a stenotic valve. It depends on what the left ventricular pressure is. Okay, so just be careful. I thought we might come to it, but since you've mentioned it in your mitral stenotic talk, it is important that you look at the shape of the pressure drop across the mitral valve before you commit to saying that the patient's got a stenotic valve.
Alison, just in 10 seconds, the case that Ali mentioned with the tear of the anterior leaflet had a very low Wilkins score, was in her 30s. We started with a 22 and we tore the anterior leaflet in half, back to the annulus. Alison was there. How do we predict that? Because I believe that a lot of the older operators are lying when they say they've never had any complications from this. I'm sure, because I'm telling you, I've done under 50, and we've had complications. That patient, Ealing and I wheeled that patient to theatre ourselves that day. because we knew that she wouldn't do well. She did fine in the end with a surgical replacement. But was there anything that we could have predicted?
But only partly because she was young. No, we looked back at it afterwards. The Wilkins score was still low.
Exactly. Thank you.
I can confirm, I had a complication this week actually, because we attempt a young patient with previous commissurotomy surgically, and it teared very quickly and in a nice way. Actually, we were thinking we opened the valve and then you have regurgitation there because the leaflet are just scared and not working well. So this happened. They
don't tolerate that new MR well, do they?
Yeah, it was moderate in that case. We were a bit lucky, but on the long term we need to operate the patient. Yeah. Thank you. So, Alison, you have already the mic, so you will present us something very interesting, step-by-step procedural guidance for transventricular neocardial implantations. I'm very curious to see that. I've never done it, or maybe once only, so I will learn.
We didn't actually have a transventricular neocord in the program last year because it is quite niche, but it is a beautifully echo-directed procedure. So I thought it would be another sort of inspiring example of why you guys are so lucky to be in the environment that you are, that potentially you can perform this type of procedure. And I think I've asked Rashmi Yazav to come and show a case in a box later on, but in case she doesn't speak about the reason why transventricular neocord can be useful is particularly if you've got a non-surgical patient who maybe has previous mitral valve intervention with a mitral annuloplasty ring that's potentially too small to perform edge-to-edging without creating a pressure drop across the valve. This is obviously still a hybrid surgical procedure, but potentially you could fix the valve or repair the valve without increasing the pressure drop across the valve and without necessarily obfuscating the patient's requirement to go back for surgery at a later date. You don't lose anything by trying, apart from the fact that patients had a procedure. And hopefully what I'm saying will become clearer once I've shown you the procedure and you've seen the images.